all about connecting health tech systems and people and hospital trusts and navigating the NHS is our own Lauren Bevan, and it's a huge privilege to welcome her to this event and have her share some thoughts with us. Over to you, Lauren.
Good evening, everybody. So I'm going to attempt to manage the technology here. So there is the QR code for Leeds Community Foundation. Our own Cleveland will be talking about that shortly. So I am setting the scene here about why this is an important problem. And as is customary, we're starting our odyssey of healthcare IT with a picture of the Backstreet Boys, because we need to ask why. Like, why is this important? Why is this hard? Why is this difficult? There's huge numbers of people in this room who have already managed to crack some of the technical aspects of this, but still we're finding ourselves having this conversation about why this is still a problem that we're all galvanised to solve. And part of that is because life has changed, but the way that we manage healthcare records hasn't. So people travel more over their lives in the last 40 years than they ever have done. The way that we manage health systems, the way we manage health records has not evolved at a similar place. We move across the country for work, for jobs, for university, for love, for all sorts of different reasons, and our information doesn't follow us in the same way that it ought to. 40 years ago, before electronic health records, we had two packets of paper. We had our GP records, we had our Lord George records, and we had our hospital records. We can't manage the complexity of care that we have now with two packets of paper. Medicine moves faster, and so do we, and the information flow needs to be similar. Healthcare is a team sport. So I trained clinically 20 years ago. We trained in silos. As part of that, my university started to train us in MDTs in the hope that it would inspire us to be able to work more in a collaborative way. But even then, I remember that everybody sat in their professional groups. So we were trying to do the right thing by coming together to do anatomy, physiology, all the things that no matter what your profession you need to understand. That hasn't necessarily changed. MDTs have absolutely become more embedded in the way that care systems work, but with deeper knowledge comes more specialists. With more specialists comes atolls. We've gone from a landmass to unconnected professional groups. But as this happens, the chain gets longer and the signal gets weaker between each of them. The technology we have now connects care teams. So you'll have all seen some of the brilliant news where people are able to, command robotic surgery from thousands of miles away. We can have connected surgical teams that work across different groups, sometimes different continents. People can actually deliver care in a connected way, but they can't actually share the outcomes of that because their theatre systems will not speak to each other. So it's absolute madness that you can have a clinical assistant from thousands of miles away, but you cannot convey the post-operative notes in the same way. We can talk to coordinate care, but we can't talk to share how we're going to plan care in the future. So where does that leave us? It leaves us with what I call precision guessing, which is not necessarily where we want to be. What that means for us at the moment is we don't know whether or not we have all the relevant clinical information to be able to make a safe assessment around what's the best thing to do for care. And what we're able to do then is we either think we have all of the information because the information we have to hand is so vast and we miss that we're making a guess, or we spend our time trying to find that information and therefore spending time not actually delivering care to patients. Either way is stressful for clinicians and it's really risky for patients. So why is it so hard? Change is hard, even when the benefits are obvious and the risks are low. It's not really the technical barriers, even though they are hard. Everybody in here has the collective intellect to solve that and has indeed probably done that to some degree already. You have to make the case for change. And in a system that's incredibly stretched with people who are absolutely knackered with estates and the maintenance backlog that we have at the moment, it's really hard to make a system change stack up as a business case, because what you're doing is making a case for something you organisationally might not get the benefit of, but the system will. So how do you make a case to leave your own organisation potentially financially less better off, your organisation more stretched because you have to have the capacity to be able to manage it, negotiate it, all of those things, in an overstretched workforce with economic constraint that we all exist in? This is harder still. Everybody in here is both altruistic and tribal in their own way, and we're all humans. The ability to say we're going to make our lives harder for the benefit of others in the system is quite a hard thing to be able to square off. And a lot of those precision guesses that I've just talked about are hidden. It's become such customary practice in the way that we deliver medicine that is really hard to size up to people. And it's even harder to be able to say we would have made a different, had we had all the information, we would have made a different care choice for that person. And that, unless the consequences of that are massive and you're in a prevention of future death report, it's really hard to be able to say, what would we have done if we'd have known? What would we have done if we'd have known that this person went on holiday and had that episode of care 3 years ago, and that's now contributed to why they're in A&E today? We don't know because it's hidden. Proving that for one person's hard, proving that for millions is impossible. So how on earth do we do it? This is a cultural problem, not necessarily a technical problem. So we need to start thinking of it as a cultural issue for the NHS and for its suppliers. And it's only through that lens that some of these behaviours make a bit more sense. Interoperability being easy is an existential threat to some suppliers' business. It involves organisations and people putting time and money and effort into something that isn't necessarily going to benefit them in the short term or potentially in the long run. It's hard to quantify benefits. It's not always in people's organisation. And up until recently, there was a massive impasse around the technical standards that were going to be used by everybody. So it was really easy for people to say, well, we're adopting these standards over here, when actually there was no consensus in the standards that were applied. Now, there is the Procurement Act, those things should start to change, but up until recently, that hasn't necessarily been the case. It's exacerbated by the number of procurement and contracting routes that the NHS can take to be able to buy systems. So what are we going to do about it collectively? So I'm hoping you're going to hear a lot of brilliant talks by people here who've got their suggestions about how to change the way that we as a system tackle this change. But I would argue that we need to reframe it as a cultural issue as well to be able to get the real change and the traction. And like all cultural issues in the NHS, it's overcome by acknowledging that it exists, regulating against it where possible, and incentivising people to work together to make systems change. This isn't going to be done by individual heroics. We all have to play our part in making sure that this is fair and equitable care for all. And I think the one thing that I would really like people to do more, everybody in this room as well, is being honest about how we failed. All of us have tried something that hasn't worked. One of the things that I think is really frowned upon, particularly in the NHS, is talking openly about failure, because it comes with it some connotations of shame. I think we need to take that away and be really honest about the experiments that haven't worked, because I think that's only then that we get that collective learning between where we're going to go next. I think we need to stop penalising people who talk about what they'd be able to do better next time, because I think we all have our things that we've tried, hasn't necessarily worked out, but we've learned a lot from it. There aren't any systems and processes in place for technology in particular to do those learning that you have to do when you're a clinician and you end up having to evaluate the care that you've provided to patients. I'd really like us to be more honest about how we're able to do that together, and then hopefully we're able to move forward. So thank you very much.